Your 10 is going to be blurry. Okay, Dr. Molu, do you want 10 in focus or 40 in focus? You can't have both. Okay, so let's do this one. Let's do this. When is it good? Is that good?
Yeah.
Good? Okay. And your phone is working, or we don't have anyone online? Maybe Dr. Basa.
Yeah, we have one from
One?
EQ. Pathology.
Okay, and this is working. Salam, do we have anyone online? If you can say something just so we know our sound is working well and you can hear us. Yes?
Dr. Sabah Ahmadullah का गाँव रे सही सही
Very good. All good to go. All right, so today we are going to do lymph node. And before we start, let's go over some WHO criteria, reporting system. So unsatisfactory or non-diagnostic, yeah, when usually when you don't have enough cells. So usually how many cells do we expect in a lymph node? FNA, lymph node, how many cells do we want to see? Many.
A lot.
Yes, we want to see many cells because lymph node
It's full of
lymphocytes and very easy to aspirate. Yes?
Yeah,
So
the
we want
slide
to-
should be like blue when
Full.
yeah.
Yeah, exactly.
Even without microscope, we have
You
to
can
know
see
this is lymph
very
node.
blue. Yes, yes, very good. So yes, you want to see many cells, right? Like this, many cells. Okay. So non-diagnostic is if you don't have many cells or very few cells, then you say, okay, you know, maybe you were not in the lymph node properly. Yeah, you didn't get a good sample. If it's suspicious, repeat. Okay. The next one is benign. Of course, benign, we'll look at some cases, inflammation, acute inflammation, granuloma, all benign, right? Atypical, again, that's a category. It's not benign, it's not suspicious or malignant. Okay, so that's like that, very gray zone, iffy, right? Suspicious for malignancy and then malignant, right? So we're going to look at all these today as we go through, right? Any questions about the WHO
Is
reporting
there
system?
any significant difference between atypical category and suspicious one?
Yes.
Like, can we say in percentage how many atypical cells will be like malignant and how many suspicious will be malignant?
Dr. Molu?
Because
I think
That
there
is
is
tough
no
question.
any specific cutoff.
No,
That
no.
we see 50% atypical, we show for atypical. And
Because
if
this-
80% it is
these two
suspicious.
category look like
Yeah.
the same.
Same, yes. So
But-
we are, let's see, maybe I have a few which are suspicious here.
Okay.
Okay, so let's look at some and then maybe we get a better sense. Okay, all right. So here we are. So let's start. Normal lymph node. What do we want to see? Normal lymph node.
Lymphocytes.
Lymphocytes.
And you
Mixed cell population. Heterogeneous cell population, right? All types. And what is going to be the majority of the cells we see?
Lymphocytes.
Hmm?
Lymphocytes.
What kind?
mature.
Mature lymphocytes. Yes, mature lymphocytes is going to be the biggest population of cells. Yeah. Okay, so let us look at some of these, and we see what we see. Okay. So here again, this is a thin prep slide. I've told Katie to pull a few cases from smears, so we can also look at smears. So you know it helps you a little bit. But as we go here, so you can tell what anything. Can you see?
Yeah.
So quite a few lymphocytes. Agree?
plasma cells.
Yeah. Yeah. So mature lymphocyte. Yeah. Intermediate maybe here. A little bit bigger, a little bit more open chromatin, less clumpy chromatin maybe. And do we see anything else? Few plasma cells?
Yeah.
Okay. You remember we talked about dendritic cells? Sometimes when you're in the germinal center, dendritic cells. So this is maybe one. They have a very fragile, wispy cytoplasm, right? And they look a bit more oval sometimes. Oh boy. Here is another one. Oval with that wispy cytoplasm. So, sometimes you can get dendritic cells as well in your sample. And we might even see those, we call lymphoid tangles. Lymphoid tangles, which are the cell clusters that come from the germinal center, right? So you might even see some of those, and perhaps that might be a small one. Okay. What else was another thing we saw with the lymphoid tangles that we said? If it's a lymphoid tangle, yeah,
Tangible
body macrophages. Okay, so anyone see, if you see one, let me know. Also, you see now we are coming on, some of these are a little large. What are these?
Immunoblast.
Blasts, yes. So those usually will have a more prominent nucleolus. Sometimes a little bit more cytoplasm. This one I can't see very good, but maybe a little bit there. Yeah, so the blast cells. So generally on cytology, you can't differentiate more than that, generally. Okay, how about mitotic figures?
We can see them if
Sometimes in reactive, we can see
Yes, if
because
it's
germinal center is the area
where it's
which we have
reactive,
lots of
yes, activity going on. So and also, but you don't want to see many. Rare tingible body macrophage is okay, right? Everybody agree? Dr. Molu, anything you want to add here?
Yeah, I think
Okay.
tingible body macrophages make me happy.
Yes, it makes you more comfortable that there is that it's it's okay. And then also few rare lymphocytes. Now you see here, what is this? What happened here?
Crush.
It's crushed. Crushed material we don't want to evaluate. It's very difficult. You don't know what it is even, right? But so it's better. We've got lots of good cells. Here's another what?
Blast.
Blast. This is a nice one. You can see there's even some cytoplasm here. Nice blast. So if we do a little inventory and we see, okay, how many mature, how many intermediate, how many blasts, can we see there is a mixed population?
Yeah.
Lots of mature. The blasts are big. They will catch your eye. You see, you notice all the blasts right away. But you see, if you force yourself to notice, look how many mature lymphocytes. Many, right? Many. Okay. So that's the main idea, is you want to evaluate what is your the whole population of your entire sample. Okay. We haven't found any good tingible body macrophages yet.
Dendritic.
Probably. Okay. All right. Oh, here's a nice little cluster. Let's look in there. Again, quite a bit of crush. Anyone see any tingible body macrophages in there? Not good. Not really. Okay. Okay. I think you get the idea. Mixed population of cells. I found one. Look. By cell. See that? Okay, so nice tingible body macrophage. Yes? Okay. All right.
Can we point out differential between tangible body macrophages and emperipolysis? Is any clear difference between these?
Okay, so what is emperipolysis?
That is also a condition which macrophage phage the other cells.
Eats other cells. So
Yeah.
that's what you want to look for. Is it usually intact other cells?
Yeah, live cells like.
Is it leukocytes or what? Lymphocytes.
Lymphocytes, yeah.
Okay. So, all right. So you see now, let's look at this one here. You see the little nuclear debris?
Yeah,
It's
these
very
are
tiny.
debris, yes.
Very tiny. Here's normal lymphocytes, right? So this, you expect them to be bigger.
Mhm.
and live full cells, intact cells ingested in here. So it would be bigger. It would be even more obvious,
Mm,
right? Does that
Yes.
help a little bit?
Yes.
Okay.
Imperial policy is a function of megakaryocyte or also macrophage?
Megakaryocyte?
Yeah, in bone marrow.
Bone
Imperipolysis
marrow.
is the function of megakaryocyte.
Salam, salam.
I wanted Dr. Ismat for a moment.
Yeah, so is
we have one more.
in bone marrow.
Scan the cells.
Macrophage, it means
Lymphocytes.
So,
platelet.
Ingesting platelets, okay. Okay.
That is complete. Empirical.
Okay. Does it
That
happen
could be-
anywhere else?
That would be a case where they think of ITP or something. right?
Yeah. So it would be very specific.
but this
Yeah.
is-
Okay. This is a lymph node, so not really likely to happen here. Yes, you could have overlapping too, but then you can usually tell. Usually it's also out of focus. So you see there's a little blob of black junk here sitting on this macrophage. Is it junk? It looks kind of like in focus. But yeah, if
Possibility.
it's sitting on top, usually if your cells are sitting on top of another cell, they will be off focus. Yeah, you can focus on one and then the other one goes out of focus. So yeah, it helps. You can usually tell that way too. All right. Okay, everybody comfortable with this? Any questions about this?
What was that?
Sorry,
Like the explanation about that.
this one?
Yes.
This is a tingible body macrophage,
Okay.
TBM. Yeah, tingible body macrophage. It is a macrophage which is we find in lymphoid samples. Okay, when you know it's a lymphoid sample, it generally will it can be benign or malignant.
Mhm.
Benign or malignant. That doesn't mean it's benign just because you see this thing, but it tells you it's a lymphoid sample.
yeah.
Okay, it is a macrophage that is ingested little bits of dead nuclear material from dying dead cells. Okay, and generally in a lymph node germinal center, very high activity, lots of cells are growing and dying, so you see this. Okay,
Mm.
does that help? Yeah. All right.
Ma'am, can we call those crushed lymphocytes as lymphoid tangles, which are under this screen?
All these groups here?
Yeah.
Yes. Yes. Yes, yes, you can. And
Mostly we
generally-
see these lymphoid tangles in reactive lymph node, or we can also see in lymphoma as well.
No, generally more in a reactive, or even if you're right in the germinal center. It's generally you see more of those when you are sampling germinal center, and usually those are like enlarged lymph nodes. So yes, more likely it's reactive.
Okay.
Yeah.
Can it be a feature of a reactive lymph node?
Yes.
Okay, thank you.
Yes, but also benign lymph node if you are sampling right from the germinal center.
Okay.
Okay.
Mhm.
All right. And yes, we do have a few lymphoid tangles on this slide. Quite a few. When you see even in your tangles, you can see a mixed population. Some big cells, some little cells, mostly the mature lymphocytes. And you can see cells around. So there's a nice blast.
Yeah.
Yeah.
Mm.
Okay. Everybody okay with this?
Yes.
Yeah. All right. Okay. And hopefully we'll get some slides, some smears from Kerry so we can actually see smear preps as well. Okay. The tangible body macrophage over here that was marked for us.
Very nice.
Oh,
Yeah. You,
You are.
right?
Yeah.
Okay. And you noticed we haven't really seen a mitotic figure. Yeah?
Yeah.
So, and I say that and I find one.
Yeah.
Oh boy. But yeah, they are very rare. Okay. But yeah, the more germinal center component you have, you will see few. Okay. So again, we're evaluating a few things. A heterogeneous population, number one, and then, what else do you have in here? So number one, heterogeneous population. The more heterogeneous, the more
Normal.
likely it is normal or reactive. Okay. Yeah, I had some history here. Does it matter where the lymph node, which lymph node for you guys? Is that critical information to know?
Yes,
Sorry?
sir.
Yeah.
Because
Usually,
Yeah.
you want to know because some tumors will go to certain lymph nodes. Yes. So yes, it is important to know
Side of.
which site. Yes. So this was an axilla from a young female.
Yeah.
Okay, the first one we looked at. Okay.
But
I
the
want-
patient had mastitis.
Yeah, there was no
breast
other history. Well, it could be, but this was axilla and it was negative. But we don't know what, I don't know what her history was. Yeah, it was negative, and yes, it was a reactive or hyperplastic lymph node. All right. All right, so this is coming from a 51-year-old female, also axilla. Okay. All right, so let's just go on low power again. Pretty good cellularity, lots of little cells. Yeah. Not so many clusters like last time. Few, maybe. Oh, something different. Okay, let's look here first and just see what we have in our background. Okay, so what do we have in the background?
Is a macrophage?
Yeah, there's a nice bean-shaped macrophage, eh? Yes. And some here, here, here. So a bit more a few more macrophages. Are they tingible body macrophages?
No.
No. See, there's no little dots, black dots. Okay. And then lymphocytes?
Yeah. Mature.
Mature. Maybe intermediate. No blast. Okay. So a bit of a heterogeneous mix. Everybody comfortable? These are normal? Not worried about anything? Not yet, right. And again, I will just point out lymphocytes, nice clumpy chromatin. Yeah, that one has all of these. You can see nice clumpy chromatin. Thin of cytoplasm. Okay, we had a little group over here. What's granuloma? Yes, epithelioid histiocytes. So looks like a cluster. Anytime you see clusters in a lymph node, you want to check them out because that is something unusual. Yeah. And so even your clusters of germinal center, you want to check them out always. All right. So you see elongated epithelioid cells. They can be quite pleomorphic. Sometimes they call them boomerang nuclei, carrot-shaped nuclei. Some of these are very round as well. So quite a bit of variation in these epithelioid cells. They have this very ill-defined, abundant cytoplasm. Yeah, some of it is kind of elongated, especially in these long cells. They typically form these little clusters. And you notice in the cluster, you see lymphocytes. What does a granuloma look like on tissue?
It is multi-layered.
Multi-layered.
Yeah, centrally necrosis covered by epithelial histiocytes, giant cells, lymphocytes.
Lymphocytes outside.
Even some of them have fibrotic.
Right.
Yeah.
Yes. So it's quite, again, a mixed population. Yes, mixed kind of look. So now you stick a needle in that and you're going to sample all that stuff, mixture. But of course, it's not in that nice arrangement. It's all messed up. So you have to kind of see, picture that, right? Okay, so as a result, this is what we see. And you want to see this mixture. Generally, so sometimes you said necrotic center. Yes, often with TB, it's more necrotic. Yes, but here TB is common, more common. In my country, TB is less common. Our granuloma is sometimes necrotic, but more often not non-necrotic. Okay, so it's a clean granuloma. It's not necrotic and more clean. I don't know how else to say it. Okay, so this was one of those. Yes, definitely a granuloma. Sometimes the granuloma, so like you said, it's layers, right? And it's usually a granuloma forms when the body can't destroy a foreign body.
Yeah.
Yes. So then what happens is your histiocytes migrate and they try and ingest and cover and form like a shell around your foreign body, whatever it is, right?
They want to limit it.
Yes. And protect the rest of your tissue from this foreign invasion of whatever, right? So your histiocytes, your lymphocytes also aggregate around and they form like a little shell. And sometimes that granuloma shell is a little hard. So when your needle goes in, it may bounce off. So sometimes your granulomas can be paucicellular or few cells.
Sometimes even they can be calcified.
Yes,
become
exactly.
calcified.
So then the needle is even more difficult to penetrate to the middle, right? So, but on X-ray, it shows as a mass, right? So just to be careful with that, because sometimes if that happens and your needle bounces off, your sample it won't be good. It'll be scant, right? But again, you are doing a 3-point check. Clinically, what is visible to the clinician? Image, what does imaging show? What does X-ray show or CT show, right? And then cytology, what do we see? Okay, so it's like a 3-point check again to make sure everything adds up. Yeah, the cytology is paucicellular, but they're definitely seeing a mass over there, and clinically, what are they finding? So, and then what are other clinical symptoms? So, you try and make it all work together. Okay, but sometimes just to be aware that granulomas, sometimes the needle will bounce off or it will not penetrate and you won't get this good sample. Okay, it might be very scant. So then you have to give your report accordingly. Okay.
Also, sometimes can granuloma appear with malignant tumors like lymphoma. Even
Yes.
in Hodgkin lymphoma, we have
Yes.
cases that granuloma is
Often.
superimposed with that.
Yes, especially on tissue.
Yeah.
You see the granulomas nearby. Yes, absolutely. So yeah, sampling is actually quite critical, quite important, and often you need guided FNA, right, to make sure you're getting to the right mass. Okay. Okay. So granuloma. Everybody good with granuloma? Yeah. And let's look at a few more groups or clusters of granuloma. So again, let's go over. You see bean-shaped nuclei, variable shapes and sizes. The nuclei are very pale. These epithelioid histiocytes, when you compare them to the lymphocyte, very pale, hypochromatic. Yeah, like your macrophage. Hypochromatic with a kind of a very well demarcated nuclear edge, like you took a pencil and you drew around. Yeah, so your nuclear borders are very clear, well demarcated, and then you have this very ill-defined abundant cytoplasm, which can be variable, more rounded, spindly, elongated, whatever. Small chromocenters, maybe small nucleoli, but usually more look like more chromocenters. That one there is a nucleolus. See that? Okay. Everybody clear with epithelioid histiocytes? And then you see your clusters of lymphocytes. So you have them in your granulomatous group as well as everywhere around. Yeah. Okay. And as we look here, you can see we even have some of these little lymphoid aggregates, but we get also these epithelioid aggregates. Lots of them. Here's another one. So if you know your needle bounced off, you won't see this nice picture. Yeah, it's going to look scanned, or maybe just connective tissue, or I don't know. Right? Okay. So that may be something where you might say, okay, you know, you're seeing a mass. I'm not seeing anything here unsatisfactory or non-diagnostic is the other term, right? Okay, good. Everybody okay with this? Epithelioid cells, okay, and granuloma.
How would you, madam, how would you sign out this case?
No evidence of malignancy, granuloma present. Either necrotizing or non-necrotizing, if you can tell the difference. Yeah, good.
Okay.
Negative for malignancy, benign, whatever terms you guys use, right? Okay, move on. This one is coming from a 37-year-old, no, sorry, 77-year-old female. This, I don't know which lymph node it is. Sorry, 77 female. And our females really do tell us their age. They can't fool us. We are in the system. You know, when you're born, you are given an ID.
Yeah.
And your ID has
can't-
your Alberta healthcare number or your
You
OHIP number and your age and
every.
that. Yeah, it's like a government issued document. Okay, so what do we see here? Something different.
Looks
Right away, we can tell. Oh,
Looks
these
bad.
cells are not lymphocytes. Can we tell?
Yeah.
Big.
Yeah.
Epithelial clusters, groups. Yes. Right away, flags are going up. Things are like, wait a minute, what is all this?
This is look like gland, that one.
Glandular cells.
Yeah, that.
This one. Right. And we haven't even looked at these on low power, high power yet. See? Can you see the lymphocytes in the background?
Yeah,
Yeah.
too
Yeah.
small
Nice,
compared
beautiful.
to these cells.
Lymphocyte. Now we have a two-cell population. This is what you call a two-cell population. You have your heterogeneous lymphocytes and this other foreign population of cells, which look epithelial. Yeah. Growing. Look at all the groups. Yeah. Look at this. Oh my God. What is this?
Pigmentation.
It's a mess. Well, okay. So there's lots of leukocytes. It's actually obscured. It's not nice. But I see, again, these epithelial cells stuck in here. So, but I'm going to go look at some of the nice ones. This was looking bad, but yeah. Now you can see here your lymphocytes and your epithelial cells all here in together, right? Okay, let's go to some of those nice groups we were looking at before. So here's one. And you see, so you see groups. That one is a little hard to see any detail, but I see a nice single cell here. So some of these are very 3D ball, smooth contour. See that ball? Smooth contour ball. Look at the atypia of that nucleus, right? Very irregular nuclear contour. Growing together. Epithelial, yeah? Contours, very coarse chromatin, prominent nucleoli, some of these. Oh, look at that one. Wow. Odd shapes. Okay, so we're comfortable. This is not good. Not good. If you have history, or you can phone up the doctor and say, hey, we're seeing some very atypical cells. And is there any history, right? That would be helpful. Now, another thing is also immunohistochemistry. But if you have history, then you can target your immunols very quickly to exactly what you want to prove. Yeah, rather than looking for everything, like, you know. Okay, so any questions about this one? So her history, we call this adenocarcinoma. We probably either had history or we probably also did immunos. We also always do some immunos to confirm. Because sometimes one cancer might put you at risk of developing a second cancer too. Yeah, a second primary. So They always confirm. Okay. Yeah, and your comment there, this looks very gland-like.
Yeah.
Yes, it kind of does, right? So sometimes we'll see some features here which kind of help us. So yes, and more often your mets are glandular, right? Adenocarcinoma is a very common mets, but we get others too. Okay, everybody okay with this? This was a really nice, obvious malignant metastatic adenocarcinoma. Questions?
Normally, we do not have fights
Yeah,
as well as history.
yeah,
So we can sign out it positive for malignancy.
yes, absolutely. You can say malignant cells are present, and then you can look for features. So sometimes with adeno, you know how you get signet ring cells? Yeah, and that one has a little something floating around in there too, right? So not all of them are doing that nice eccentric. Some of them are actually quite high NC. These two actually have more cytoplasm. The others have very little cytoplasm. But you can look around for hints. Mitotic figures will help, more confirm that yes, something's going on, right? You describe these cells. Yeah, if you don't have IHC, you can look for hints of something. So she's a female, 77. I don't know which lymph node this was, but that would be helpful, right? Anyway, but yeah, you can say these cells have features of adenocarcinoma.
And I don't know, is it obvious in cytology or not, but in histology, when we find lymph nodes with metastatic deposits on them, they can show pigmentation. And I also see here some of pigmented aggregates of cells.
So
Maybe
show
that's
me
also a
pigment. Okay,
clue.
so something like this.
Yeah.
Okay, so good question. Okay, so what kind of pigment is this? So pigment can be a few things. Sometimes it can be hemosiderin
Yeah.
pigment. Hemosiderin looks like what?
Brownish pigment.
More
It depends
red
on the
More red, yeah.
stage.
on
Yeah.
the stage. Yeah,
Yeah.
hematoidin. Usually it's more red, orange.
Yeah,
Yeah, red, orange. Okay. And also, is it refractile?
no.
Hematoidin, hemosiderin, is it
It-
refractile?
Yeah, because it's broken down.
Yes, the broken
lies
down product, yes,
small
and when it
fragments.
becomes a globule, it is a little bit refractile. So those things can be helpful. Okay. I see some pigment here. What color is it?
Black.
Very
blackish,
black. What shape is it?
Terrible.
Very angular. See that?
Mhm.
Very angular. Okay. What do you think this pigment is? We don't know which site we're in, but what do you think this pigment is? What is black, opaque, and
Melanie?
angular? Nope.
That
Black, opaque, and angular. Which pigment? Carbon.
Mm,
Carbon is very black, very opaque, and very angular. And it can be quite chunky. This is actually quite small. It can become quite chunky. So where do we get carbon? Which sites would likely have
Lung,
carbon?
if any.
Lung,
Lung.
exactly. I bet you this was a mediastinal or somewhere there lymph node. They went through somewhere and picked up some carbon somewhere. Okay, does that make sense? I don't know
Yeah.
for sure. I can't confirm. I don't know which lymph node this is coming from, but likely. Okay, does that make sense? Okay,
Yeah.
so this I'm thinking is carbon pigment. It's very black and very angular. I have a few other pigments coming up. We will compare. Okay, but you see these ones are very black, very chunky, and you're right, there's some pigment. And you see some of it is almost ingested into a macrophage. Yeah, almost like an alveolar macrophage. It might be even a smoker with such heavy pigmentation. Yeah, makes sense?
Yes.
Okay, good thing you brought up the pigments. Okay, what other pigments can you have? Melanin, of course.
Yeah.
Yes,
Hemosiderin and
hemosiderin, melanin.
uh,
Any other pigment?
tattoos.
Oh, tattoo.
Melanin,
What is
tattoo.
tattoo pigment? What is that? What are
I
they
don't
putting
know
in?
exactly.
yeah, yeah.
Dye? Yeah. Right. What would it look like? I have no idea. What would it look like? Is it carbon?
Black, yeah.
It's black. Okay.
It depends on the tattoo because they use different colors.
Mhm.
The
It may
mechanism
not be.
is the macrophages phage that color and express it to the skin.
Right. Okay. So tattoo would be usually it's just skin deep.
Mm.
Yeah. It's not going into your deep lungs and organs. Yeah.
Yeah.
Lymph nodes. Right. Okay. All right. So yes, very good to consider all your pigments. And if it is hemosiderin or blood, you would also expect to see, now you see that one looks a little orangey. See that?
Mm.
You would also expect to see blood around.
Mhm.
Okay. This one is a bit clean. I don't see too much blood in here. Okay. Okay, good. So we've talked a little bit about pigments. Great. Okay. This is a lymph node lung, 4R. Yes, 4R. You know what that is? One of the mediastinal lymph nodes. Yeah, in the lung. Yeah.
Some of the highlight.
Hilar nodes. Okay. Okay. Can we get a map? It's in CBUS, I think. All the lymph nodes.
Yes.
Yes, we'll maybe get a map of that, where all the lymph nodes are in the hilar, mediastinal area. Okay, so this was
It's
a
like
4R.
sentinel lymph node, something special about it.
Yeah, so 7, 4, 11, those are usually the lymph nodes that they sample when we are doing a bronchoscopy and staging,
Mm.
kind of. Okay, so this is coming from a 78-year-old male. Okay. Mm. So we have something, we'll look at this, but I want to also look around. Do these look like lymphocytes?
No.
Too big,
Yeah, abundant.
growing together, too much cytoplasm, too big, little atypical. Hmm. Not a lymphocyte. Don't know what it is. Doesn't look great. Okay. Atypical again. And here we have a few more cells. Some marks. That's that first one we saw. Can we agree? These look foreign. Not lymphoid. Maybe epithelial.
Respiratory.
Hmm?
For now, we are not sure. Are we in lymph node or not?
Yes, because we have no lymphocytes, right? Okay. And on our report, usually they want, so if there are abnormal or atypical cells, it doesn't matter. Because usually these first procedures are all done under ultrasound, guided, right? So they know, if they're telling us 4R, they are likely in 4R, okay?
Mm.
Okay, so we trust that, yes, this is a 4R, it was a guided procedure, yeah, and they were in, and there's no lymphocytes present in the background. If you know, when we give a diagnosis of benign, they always want to say abundant lymphoid material was present if we're giving it a benign, right? But
Mm.
this one doesn't matter. We actually
Yeah, we
don't.
have the darkest color here, and
Yes,
we'll go with that.
Yes, so we already have some cells which are non-lymphoid. They're telling us they're in 4R. Okay, there's something going on. Yeah, so we have to assume that these are not lymphoid. This is some foreign population. Now we're going to investigate, is there some history? Male, 78. Okay, and hilar lymph node. So likely something going on in the lung that has now metastasized into this lymph node. Okay. All right. You see something under this mark? It's too bad it's right under the mark. What does that look like?
Keratin.
Yeah. You see that?
Mm.
Keratin blob.
Keratin,
Pardon?
keratin.
Yes. Agreed.
Lots of squamous cells also.
Yeah. And look at some of
Visible
these
at
cells.
the-
You see, and I was looking at this. Where did it go? This guy. Abundant cytoplasm. Look at that nucleus. Almost that dark hyperchromatic India ink. Yeah?
Mm.
See that? Very pleomorphic. A lot of single cells, which is also another feature of squamous. Yeah? Not all of them are keratinizing, but there's the odd one. Look at that. See that? A typical keratinizing. Should we see keratinizing cells in the lymph node?
Mm.
No, never. Okay. So, so even seeing keratin debris should immediately raise a flag. Okay. Squamous. Start thinking squamous or something along those lines. Mixed. Could be a mixed tumor too, but yeah. Okay. So, and you see how there's a very dispersed cell pattern here. A lot of single cells. It's a very squamous feature. Look at these cells with like almost little tails. Tadpoles? Almost, yeah. This one here was a better one. This another tadpole here. Yeah. Very atypical nucleus, hyperchromatic, coarse chromatin. We've seen lots of irregular shapes and another tadpole there too. See some hints of something. Little debris, another keratin debris here. Orangophilic, blob, glassy, dense. Yeah. Yeah. Very atypical cells. Yeah. Nice tadpole with such coarse chromatin. Irregular, clumpy. It's still round, but it's not good. Okay. Are we comfortable that there's actually enough here that we can call this malignant
Yeah.
and suspicious and give a description to say we are suspecting squamous cell carcinoma here? Yeah. Likely squamous cell carcinoma. We could phone up for history. I bet you this guy has squamous lung CA. Yeah.
Mm.
Okay. Yeah. Are we good with this? So even though it looked kind of scant, there's actually lots of cells. There's quite a variation of sizes. Some of these cells are so tiny, but they are, or none of them are lymphocytes, right?
Yeah.
Agree?
Only one.
Oh, maybe that
Come.
one. One lymphocyte so far. Yeah, few lymphocytes. But yes, lots of these very atypical foreign cells. Okay.
Yes.
Any questions? No? Good. Okay. Ah, recent that. Okay. Yep, that was a metastatic squamous cell carcinoma. Okay, we look at Katie's slide now. Any history? Anybody look this history up? Dr. Modasir? PC. Oh,
Like this.
1512.
Left side neck,
Left neck. What else?
22-year.
22-year-old male. Female? 22, female, left neck. Query reactive, query TB. Okay. Is this a peptide? Oh my God. Ooh, blue, very blue. Okay. Yeah, definitely, right? Definitely satisfactory. Okay. We go down, we look at what's in here. What do we see?
Mixed population.
Lots of lymphs.
Side.
Lots of lymphs. Mixed population?
crash.
Yes.
Lots of crush. Yeah.
The size of cells are looking different size.
Yeah, various size cells. So I have mature, I have a bean-shaped nucleus or a little elongated, a little bit. Yes, very, yeah, heterogeneous population. A lot of crush. This is common in a smear, especially lymphoid cells, very fragile. If you squish the slides too much, you crush all your cells. So yes, a crush is common.
Plasmids.
So all kinds of cells. All right, they're querying reactive query TB. Can we see anything? Are we going to look for granuloma?
Yeah,
Okay. We look for granulomas.
like so.
You saw some?
Yes.
Is this it? Not great. Maybe. We're gonna look around. Yeah. Yeah, could be. Mhm. Can you see necrotic?
Yes.
Yeah. So
The doctor also suspected TB.
yeah, they were suspecting TB. Can we confirm TB? There's something outside. Anything helpful here? No?
Maybe here.
What do you see? Any, oh, is this good?
Yeah, this one. Oh, lots of epithelials.
Epithelioid histiocytes in here. Yeah?
Yeah.
The spindly carrot shape. Very, very spindly. Yeah. Lots of cytoplasm. Is this the orange stuff that's staining like cytoplasm? Or what? What do you think?
The orange
Yeah, this background orangey
maybe proteins, debris, granuloma.
granuloma. The
Other cell cytoplasm is not this orange color.
yeah. It's almost like what you see on tissue, layers. Yeah?
Yeah.
Your central necrotic. It's almost all necrotic, isn't it?
Yes, cellular.
In here.
Yeah.
And then here's your little layer of lymphocytes and epithelioid cells. Yeah. A lot of necrosis. Yes, we can confirm some TB.
Mm.
This might be a little bit better to see those epithelioid cells here. Yeah. Okay. Yeah. Good. Okay. Anything else you want to add, Dr. Moshtaba? Thank you.
Generally, it's interesting that in lymph nodes, even from crossing, it is in contrast with other organs. Like when you see homogeneity or solid architecture in lymph node, it means bad.
Yeah.
But if you see in other organs, homogeneity, it
That's
means
a good.
good.
Yeah. So you
But
have to really.
even in cytologic features, when you see polymorphism and mixture of cells, it means good. But then when you see monoclonality, monomorphic cells, it means bad. Something is going like
Yeah,
lymphoproliferative disorder.
Exactly. Yeah. So it's a little opposite for lymph node. Yeah. Good point. Very good. Okay. Everybody comfortable with this one? We can say negative for malignancy, consistent with TB. Granulomas consistent with TB. Necrotizing granulomas. Okay, very good. We had another slide or what? Is it different?
Yes.
Same case. There's no label on this. Oh, really? Are you sure? Not same case.
This is one is not same
This
case.
is not the same case.
There are 4352 at the end. But no PC. Yeah. Khadira? Yeah.
Oh, so it's the same thing. Interesting. Is this a lymph node? Also from the lymph node? Oh, this looks a little different, doesn't it?
Mm,
Big cells.
yeah.
Big cells, mature lymphocytes as well.
Yes.
Kind of looks mixed, doesn't it? Looks scary though.
Yeah.
Some very scary looking glasses. Okay. Now it looks like yellow. A little bit. Yes. Yeah, these look like the same kind of necrotic.
Material.
The patient had two pathology.
Well, so even though this looks scary, there's still, it's a mixed population. And you can get some pretty reactive lymph nodes and some pretty dramatic change. What is everybody thinking?
I'm looking for eosinophils.
Eosinophils.
Yes,
Are those common also with
And
Hodgkin lymphoma. I'm trying to
Hodgkin's?
pull out those large cells.
Yes.
But those are not
RS.
RS cells because
Mm-mm.
the nucleoli is not prominent.
Mm.
I didn't saw any binucleation.
Binucleation
Although
or
they can have
multinucleation.
been.
You can see mononucleated, but yes, eosinophils, and then you see a normal lymphoid background, right?
Mm.
Yeah.
Yes.
Although the specimen is very poorly preserved,
Yeah.
but hypercellular.
Yeah. Yes, it is very solid.
I think we should also consider a lymphoproliferative disorder, at least suggest. I don't know, but
yeah,
LPT.
because there are scary cells
yeah, right.
and they're very hypercellular. I don't
yeah.
think so. If we could find that much cellularity in granulomatous lymphadenitis.
No, this is too much.
Yeah, that's sheets of lymphocytes.
it's still a mixed population. I think it's just, but there's a lot more blasts. Looks like
Mhm.
more blasts visible here, but there are still, if you look, there's a good number of mature lymphocytes in here, right? But yes, I agree. These blasts are a little bit scary. But we have seen where, you know, we can get a really reactive lymph node, you know, Rosai Dorfman, stuff like
Mhm.
that, where you can really get some very atypical, yes, yes. And
And if we look for that wide stones, tangible body macrophages,
yeah,
that might also help us toward the
yes,
reactive.
yes, yes. So I saw a few, there's not tons, but there's a few in here.
Yeah, this
Yeah.
one is.
This one here, yeah. In here maybe, I don't know, not good, but okay. Yes, the tangible body macrophages in here. Maybe you can see tangible body also in malignant, but then you also see a more monoclonal population, right? And if we look in here, I think we're seeing similar groups of that necrotic debris and the, I haven't seen great epithelioid cells, but there's that debris in here. But yes, I think you're right, Dr. Bassett, that, you know, maybe consider some lymphoproliferative, or how would they figure it out? What would they do? Is there
They
something
will
else we can
excise the
do?
lymph node,
Ah.
centralized systems.
Okay, that's it.
Yeah.
And then you can confirm.
In cytology, there is no other step
Nothing
here.
else.
Yeah, it's stop.
That's it. Wow, okay. I guess it's better to be safe than, you know, have something growing in there, right? Okay. All right. Okay, are we good with this?
So how are you saying this?
So Dr. Bassett was saying that this is looking, it looks a bit like lymphoproliferative even, with these really scary large blasts in here, too many. And so he was suggesting, could there be a lymphoproliferative process going on as well in the background with the TB? The other slide was confirming TB, right? And they said for in here, if you give a diagnosis lymphoproliferative, they will remove the lymph node. That's it. There's no IHCs or anything here. So, right? Would you agree with that, Dr. Molu?
I think, as a pathologist.
Yeah.
I also tend to err to what Dr. Bassett is saying.
Yeah.
Calling things lymphoproliferative.
Yeah.
Just to cover myself.
On the safe side.
And to cover myself, in case it turns out to be something.
Yeah.
And I call it negative, then I'm in trouble.
Trouble.
I think our use of lymphoproliferative is liberal.
Yeah.
Depending on.
Yeah, I guess again here you have limitations. You know, you don't have all that IHC ability to do. Yeah, and we would do flow. We would do all kinds of things over there, right? Which would give you a really good idea. Yes, absolutely. And IHC is like no problem, right? So yes.
Your hands are open.
Hmm?
You can do everything.
Yes, yes, absolutely. We have really, I mean, it's advantages, right? It's a developed country. So we have some advantages which you guys have very limited over here. Okay, no, I agree. Good. Okay, move on. Thank you. That was a good case. All right.
Let's sign out. Should I give it?
Dr. Mustafa,
بالأخرى
put his name on that one.
LPD.
Yes. Okay, so actually,
LPD.
Yes.
Lymphoproliferative.
CNGI am mentioned connect will LPD all LPD was CNGI.
Chronic granulomatous lymphadenitis with associated lymphoproliferative disorder.
exactly, yes.
Okay, thank you.
Yeah. Very good. Okay, so that case we looked at the one where we said, you know, looks like squamous cell carcinoma. I actually have a cell block on it too. So here is our cell block. And
Mm.
actually, it's got some very nice cells. So, yeah, even though it's just a cell block, not tissue, but what do we see? Tell me. Tell
Sheets of squamous cells with
Yeah.
keratin.
keratin.
Cell block is easy.
Yeah, see? Should have put this on first, right? Yeah, but it's good to see the cyto on the thin prep, and then you confirm on your cell block and you say, yep, there it is, right?
It acts like a external control for you.
Yeah, a second
Cellular
control.
bridge, yeah.
Absolutely, yeah. See the cellular bridges? Yes, and I think there's even mitotic figures in here, maybe. Okay, yes, very good. So we were on the right track. Oh, nice mitotic figure there. Mhm. Lots of them, yes. Lots. Very good. And we can see a little bit of keratin debris here. Yeah. Can we see keratin pearls? I don't know. Have we talked about keratin pearls? Where, you know, the cells wrap around each other. Yeah. So lots of keratin debris. Look at all that. And let me see if I can find a nice pearl. Oh, look at all those cells. So, pearls are, wow, look at this cell block, okay? No, I don't see any pearls, but
Here is an ill-defined one. I
Hmm?
don't know.
ill-defined. You see one?
Yeah, the top of this nest.
This
These
one?
areas.
Yeah.
Mm.
So it's starting to wrap around. Yeah. Yeah. Ill-defined is exactly right. Okay. Maybe we'll find one somewhere else. Let's see. On another case, maybe. But yeah, here's our cell block for this squamous cell carcinoma. Yeah. We weren't making it up. Beautiful. Wow. Oh my God. Look at that.
So the thing is, you don't need a biopsy for you to send it to for tumor.
No. No. Yeah.
So the cell
This
will
is it.
for-
Yeah. Absolutely. Yeah.
So for squamous cell carcinoma with tumor marker, we send it for server. Let me give you three choices: EGFR, KRAS, PD-L1.
Here. For
Squamous cell carcinoma.
squamous cell,
Mhm.
to confirm it's
Mhm.
squamous cell.
No, so the PDA tumor marker, no PDA. So that's right. The PD-L1 tumor marker, then it's targeted therapy if it's positive.
I don't know, sir.
Did you understand?
No, sir.
Yeah.
So when you start treating squamous cell carcinoma, if they are PD-L1 positive,
Oh.
then it's targeted chemotherapy. If it's negative, then
Mm. PD-L1. There you go. Very expensive and only done in certain regions, certain testing regions, right? I know in Alberta, that's how it is. I think they all go to Edmonton for PD-L1.
Although there are 2 or 3 sites
That do it? Yeah. So it's so expensive. So they, you know, collect and do them together. Okay. Very good. All right. That was the cell block. Okay. Now let's see. Let's do something different. Let's do something. It's number 5. All right, this is number 5. This is a lymph node from where? Well, history is a 21-year-old male. And I don't know which lymph node this is. That's terrible. It's not very good. Okay. All right. 21 male. Really 21. Okay. So, yeah, that's important, right?
Yeah. In males, we don't have that case.
No problem. They will tell you their age. Maybe even older, you were saying.
Sometimes, yes.
Okay. All right, so what do we have?
Lymphocytes.
Look normal, mature.
Yeah.
Yeah, one mitotic figure here.
Yeah.
See that?
Yeah.
Oh, that's a little. Oh,
Oh, this is